topic for today is regenerative medicine for orthopedic conditions. And I'm going to give you an overview of what platelet-rich plasma is, stem cell therapy, and basically just what we do and how it works for orthopedic injuries. Okay. So a lot of you know me, Mary Ambach. My primary specialty is physical medicine and rehab. I also have a certification in pain medicine, but the focus of my practice is in my fellowship training, which is orthopedic sports and spine, and orthobiologics and regenerative medicine. Been doing this for a while. Moved to San Diego maybe about 2010, so what's that, 15 years ago. And from a traditional musculoskeletal pain practice, I've switched to regenerative medicine because I've just been basically frustrated with cortisone and nerve blocks and all the standard treatments that we offer that insurance covers, because it doesn't really take care of my patients' pain, and it just kind of gives them a band-aid for a few months. And so I did some training in regenerative medicine, and ever since then, my practice focus has been using natural treatments to actually repair injuries and not just to mask the pain. So this is my clinic in Encinitas, pretty central in location, I feel. I started here about a year ago. I was working with Chris Rogers prior to that for about 5 years. Chris and I are still working together on some studies on cultured stem cells coming from fat for orthopedic conditions. This is what my regular room looks like. I'm using ultrasound for all my procedures. And then I do have another room that has shockwave equipment as well that I use for my athletes at play, or for those who don't have the downtime to do regenerative procedures. This is my spine room with the fluoroscopy machine. I do have an on-site laboratory where we process all our cells, and so we do have our cell counter. A lot of physicians who do this not on a full-time basis don't really do a cell counting, so don't really know how much platelets they put in their PRP, or don't know what cells are included in their PRP. So it's always good to have a cell counter. You can see the hood where everything is processed in a sterile manner. So PRP, just for a summary, we'll talk briefly about PRP, stem cell therapy, the scientific evidence, and then we're going to go through the Q&A session after this. Hi, Paul. How are you?
Good. How are you?
Good, good. Do you mind just turning off your video for now, and then we'll turn it on
Sure.
during the Q&A?
Sure.
Okay, perfect. All right. So, regenerative medicine is based on the concept that our body has an innate ability to heal itself, and we're just harnessing those cells to basically help it heal faster, quicker, and in a more effective way. Orthobiologics is a big word, but it just means cells and the molecules that are derived from the cells that help promote the healing of orthopedic conditions. And this composts of platelets, stem cells, and other proteins and cellular molecules like growth factors that help in the healing process. So let's talk about platelet-rich plasma. There's the whole blood that is in our vascular system, and it's composed of the liquid portion, which is the plasma, and it's got different kinds of cells in there, of which platelets is the cell of interest for our discussion today. And the reason why we are interested in platelets is that because not only do they function as the first responders to injury. So basically what they do is that whenever there's an injury, they go in there, seal in, and create some clotting to stop the bleeding. But more importantly, as a secondary function, they do secrete all these growth factors, and there's thousands of them, that will help initiate the healing process. So the platelets has about 3,000 growth factors. Their main functions are as follows. They do modulate inflammation. They help stimulate the cells like stem cells and other cells that are involved in the healing process to go to that area of injury to promote healing. And they do stimulate blood vessel formation, which is important for tendons and ligaments, meniscus, cartilage, because they don't have a good blood supply. So what is PRP? The definition of platelet-rich plasma, or PRP, is a highly concentrated amount of platelets, more than baseline. Normal platelets is 150 to 400,000 per microliter. Usually when we prepare a PRP, it's usually about 5 to 10 times more than baseline. So you're talking about billions of platelets in an injection. Usually per ml, we get about 1 billion of platelets. And you can see on this image here the different cell layers. You got the red blood cell in the bottom, the platelets is in that buffy coat or in the middle cell layer, and then the plasma, the liquid portion, goes on the top. So how do we make PRP? First, we do the blood draw, and this is usually anywhere from a 60 to 120 ml. Just for reference, 1 tablespoon is about 15 ml, so that's about 4 tablespoons of blood. That's the typical volume. 60 ml, we do tend to get more depending on how many structures we're injecting. And then we put them in the centrifuge machine to spin the whole blood, and that separates it to different cell layers. And then as you can see here, you've got the different layers of cells, and then we pipette the portion of the whole blood that we don't need and just leave the platelet portion. So usually what the PRP looks like here, sometimes it's a little bit more orangey than that, depends on what cells we include in the mix. So this is actually really interesting. This is a colleague of ours from France. He's a researcher, and he took out his blood and he used different centrifuge systems to spin his blood and make PRP. And as you can see, there's this is 7 different kinds of centrifuge systems produce different kinds of PRP. And so when your patients talk about PRP and they say, well, it didn't work for me, know that there are different kinds of PRP. It depends on the centrifugation protocol that it's processed, what kind of centrifuge system they use, etc. And right now in the market, there's about 64 PRP centrifuge systems, and there's probably more now. And this Magalon actually did the study and showed that more than half of the centrifuge systems do not make enough PRP sufficient to treat osteoarthritis. And so that's why it's important to count the cells to know, what kind of dose we're delivering to the patients. You're probably well aware of the downsides of using cortisone. It is good in the sense that it does give you immediate relief, and in some instances it might be good for patients if, let's say, they have a life event that they need to have immediate pain relief for. It gives you an immediate relief, but it's short term, and the downsides of it is it's toxic to tissues. It does accelerate cartilage degeneration, and it's harmful to tendon cells. Versus PRP, which, because we're healing the injury, there's longer term pain relief. It does improve cartilage quality, and it does heal tendon injury. So let's talk about knee osteoarthritis, which is the #1 condition in orthopedics that we use cell therapy for. And the way that the platelets work is it does modulate that microenvironment in the knee so that it creates an environment that's more conducive for healing. There's always an imbalance of tissue-forming proteins versus tissue-degrading proteins in an arthritic knee. And usually when you have arthritis, the tissue-degrading proteins are the ones that always wins. So what PRP does is it switches that balance such that it creates more of the proteins that are conducive for, sorry, my light just turned off on me, that are conducive for tissue healing. So it modulates inflammation, It's chondroprotective because it diminishes the cells that are what we call catabolic or degrading to the cartilage, and it slows down the degenerative process. It also knocks out the pain signals, and quiets down the nerve sensitivity. So it does have that analgesic effect as well. Um, there's a lot of evidence, and it's not just regular evidence, but it's high quality evidence that shows that PRP is effective and safe for knee osteoarthritis. And surprisingly enough, we've got more evidence in the use of PRP for knee joint osteoarthritis than all the surgical treatments that are out there. And so when you see RCT, that means randomized controlled clinical trial, which is our gold standard in human clinical trials. So there's about 40, there's more now. This is a 6 month ago data, but there's about 40 randomized controlled clinical trial that shows that PRP significantly relieves pain and improves function for joint osteoarthritis. And I'm not going to go over all these studies, but again and again and again, they showed that PRP is superior to the different controls that they use in the studies, and most of them use either a steroid or a hyaluronic acid, which is HA, or patients call them the gel injections, or saline injections. With regards to tendon injury, there's two kinds of tendon injury. One is a tendon tear, and then another one, which we see more commonly, is what we call tendinopathy. And tendinopathy just means chronic microtrauma, wear and tear into the tendon. And so it's a precursor to a tear, because basically if you see a worn out tendon, most likely there's some micro tearing in there. So you know the causes of chronic tendon injury: either there's an overuse and an overload, wear and tear from aging, and obviously traumatic injuries. And what PRP does, just like for the knee or joint osteoarthritis, it does stimulate tissue proliferation. We've got hundreds and hundreds of before and after pictures of partial tendon tears that healed after PRP. It's kind of one of those slam dunks for us. If there's a partial tendon injury, PRP does really well for it, as long as you get the right platelet dose. That's the caveat. And then it also stimulates blood vessel formation, it modulates inflammation, and decreases pain. Most of the studies on tendon is on tennis elbow, but there's more and more data now to show its use for basically all the other tendons in the body. Golfer's elbow, partial hamstring tears, Achilles tendinopathy, patellar tendinopathy, rotator cuff, probably the second most common tendon that we treat, and then glute tendinopathy, glute mid, glute max. And it wasn't included here. Plantar fasciitis is also one of the things that we treated with. Ultrasound imaging is something that we use a lot of, not just for diagnosis, but also for precise injections, in order for us to be able to localize where to put the cells. So for a tennis elbow, for example, this is your common extensor tendon in your lateral epicondyle. You can see the bony signal here, which is hyperechoic, or this white line. Normal tendon looks like this. You know, a tendon is like a rope that has fibers in it, and the fibers are white on ultrasound. When there's a tear, you'll see that hypoechoic signal, or that black space, because there's an interruption of the fiber, so you don't see that white line of the fiber there. So that's showing us the tendon tear. Also, lots and lots of data are now coming out with regards to the effective use of PRP for for tendon injuries. The tennis elbow was the first studied, so it's the one that has the most peer-reviewed medical literature, more than 26. Mishra, actually, interestingly, is an orthopedic surgeon, and he was the one who published the first RCT on tennis elbow. And he basically said, don't do surgery on these guys, use PRP, which is rare for an orthopedic surgeon to say. So cortisone, based on these studies, only give short-term relief. And when they compared PRP versus the cortisone, PRP usually starts working at about 1 month, where the cortisone effects usually starts to wean off. And then PRP was found to be more effective with better function in these patients. This is one of the patients that we've treated in the clinic. As you can see, the tendon tear here. 6 months after the PRP, there's filling in of that hypoechoic signal or tear with the white fibers, which is the ingrowth of those tendon fibers. One of the things too that is telling of a diseased tendon is it gets thicker. So if you see this yellow marks here, you see how thick this diseased tendon is. And that's because of scar tissue, abnormal tissue that proliferates whenever you got a chronic tendon injury. And when you do PRP, it changes that tissue to more normal tendon tissue, and it creates a less thickened, more efficient tendon. So that's one of the things that we monitor, is the thickness of the tendon after a PRP injection. Glute tendinopathy as well. Most of the studies are on glute max, glute mid tendinopathy. This is just one of the studies showing that when they did cortisone versus PRP, the PRP did significantly better at 82% versus 56% for the steroids at 3 months. And the PRP group had sustained relief at 2 years. Actually, Jane here, Fitzpatrick, she is a sports medicine physician from New Zealand, I believe. And she just published her 4-year data on glute tendinopathy. Basically, what she was showing is that even 4 years after a PRP injection, there was still MRI improvements that is being shown into that tendon that had 1 PRP injection, which is, it's really great data. This is one of the patients that we've treated in clinic. This is a rotator cuff tendon tear. This is your humeral head here. This is the tendon right here. This whole thickness is your supraspinatus tendon. And you can see a 0.5 centimeter tear of the supraspinatus tendon here with 1 PRP injection. This is the after picture, and you can see some filling in of the of that disease or that tear, disease region or the tear with normal tendon tissue there. PRP for the spine, just really briefly, most common problems that patients come in is sciatica or nerve pain. Lots of preclinical data, animal data, that shows that PRP stimulates nerve regeneration, remyelination, basically showing that it stimulates nerve repair. There's human clinical trials on using it for peripheral nerves like carpal tunnel syndrome, and other nerves like sciatic nerve. And we basically use that data to start using it for spine. And now we've got lots of RCTs on using PRP epidurally for radiculopathy or sciatica, showing improved pain, improved function in these patients. And so the PRP does enhance nerve repair, it reduces inflammation, improves blood supply, and showing superiority to cortisone. I think we've got at least 6 RCTs now on comparing PRP versus cortisone for epidural injections. And then this is one of the areas that I had a lot of research on, is using cell therapy for disc degeneration. There's literature evidence showing that injecting cells into the discs, either PRP or maybe a bone marrow derived cell, does increase water content in the dehydrated or degenerative discs, decreases inflammation. It promotes, again, a healthier environment for the disc tissue to proliferate, and then it stimulates cell matrix proliferation, which is that collagen matrix into the discs. This is one of the early studies that we did comparing, wherein we did a single injection of PRP or bone marrow cell therapy into the patients. And our results at 12 months showed that 93% of the patients showed greater than 50% pain relief and improved function. It was a safe injection with no serious adverse events, and 80% of these patients with mostly chronic low back pain decreased their medication use after a single injection. And then we followed that up with a more high-level study, randomized controlled clinical trial, multi-center in the country. There's 4 centers in the country that we did this. And basically we compared a control versus a PRP injection versus a bone marrow cell therapy into the discs. And we found that both the PRP and the bone marrow was superior to the control, no serious adverse effects, and that it did help with this patient's pain and function starting as early as 1 month. One of the before and after pictures showing the effects of PRP for disc tears, or specifically annular tears. So this is a cross-section of L4 discs. These are your facet joints here. This is your spinal canal. And you can see this white signal, which is the posterior annular tear at L4. And this is 4 months after a intradiscal PRP injection. You can see the resolution of most of that annular tear there. And I believe this is the same patient showing a sagittal view. This is 3, 4, and 5. You can see these white signals are your posterior annular tears. And 4 months after the PRP, you can see resolution of those tears, which is pretty significant. And then the way that we treat spine is, because it has multiple pain generators, is that we do multi-target injection in the spine, which means that we inject not only the discs, but also the joints, also epidural space, also the muscles, also the ligaments. So it just depends on what we feel is contributory to that patient's instability. You all know there's a lot of pain generators for patients who are seeing you for their low back pain, and most of the time it's not just a joint pain. Most of the time, some days, I have sciatica, and some days it's their SI, some days it's their muscles. So you kind of have to include all of that when you are treating these patients. And so we tested that hypothesis, and we did this clinical prospective case series using personalized multi-target PRP injection, and our results have been really great. I don't know if I included it here. Yeah, but the results were, there was about 40 patients that we included in the study, and with this approach, patients actually did really well with the single multi-target injection. So very briefly, stem cell therapy is, or what patients call stem cell therapy, more appropriately we call it cell-based therapies, because if you say stem cell therapy, that really means a purified stem cell, which is cultured stem cell. And in the clinic, we are only allowed to use tissues that contain stem cells, and these are tissues from either your bone marrow or your fat, and we call them MFAT, or microfragmented adipose tissue, and BMAC, or bone marrow concentrate. So let's talk briefly about that. We know that we do have stem cells in our bodies, and we are particularly interested in this subgroup of stem cells that's called mesenchymal stem cells, because these are the ones that produce the orthopedic tissue that we are interested in. So they differentiate into either bone, tendon, cartilage, or muscle cells. So we call them MSCs. That's the stem cells that we're interested in. This guy Kaplan is actually the one who discovered MSCs, And they basically, what he found is that these MSCs were just living right next to your vessels here, and then whenever there's a tissue injury, they get activated, they wake up, and then depending on the stimulus that's given to the cells, they differentiate into whatever tissue is needed. So MSCs is like what we call them, like a mobile drugstore, because once it's activated, they release all these proteins and their cytokines that basically heal the tissue. It modulates inflammation and it also fights infection. This is a pretty cool video of, I think this is a fish that is showing how stem cells are just intelligent enough to know where the injury is, and from the perivascular region, this is the vessel, that's where they live, and they just kind of move towards the area in the skin where the injury was. So what kind of stem cells are we allowed to use? So we've got the bone marrow cells and we've got the adipose tissue, or the fat cells, and basically this is what they look like. Bone marrow, we take it from the very superficial posterior iliac crest bone, so we call that PSIS, posterior superior iliac spine. And then the fat, we take it from either the buttock or the abdomen. Those are the most common areas where we take it from. You're probably hearing a lot about amniotic tissue, umbilical cord blood. Those are birth tissue derived stem cells, not permitted right now by the FDA to be used in clinics. Only way that you can get avail of this legally is under a clinical trial. And the reason being, the safety and efficacy have not been proven. Lots of cases of bacterial infections have been published, but by actually colleagues of ours who tested these products, and when they tested it, they actually showed that there were no living stem cells in these products that claim to have stem cells in them, because as the cells go through the process of sterilization and cryopreservation, these cells die during that process. And so by the time it gets to the patients, what the patients are getting are really dead stem cells, and it's mainly composed of growth factors or proteins, which your growth factors is better and more efficient and have better quality than the ones that are obtained from other sources. So which cell-based therapies are compliant right now with the FDA guidelines? Just these three. Bone marrow derived cells, so we call that bone marrow aspiration concentrate. Microfragmented adipose tissue. So these two are what patients know as stem cell therapy, because they're the ones that's got stem cells in them. And then PRP. These are the three that we can do in clinic. These are just before and after pictures of stem cell treated condition areas in the body. I think this was a knee treated with adipose derived, which is fat derived cell therapy. You can see the cartilage, which is this white portion here. This is an arthroscopy. And then you see the bone underneath it, what we call the subchondral bone, because the cartilage was gone or worn out. And then they did a second look arthroscopy after the cell therapy derived from fat, and you can see covering of that subchondral bone with the cartilage, normal looking healthy cartilage tissue. This is a before and after MRI after a bone marrow cell derived therapy. The yellow and the red colors here are abnormal cartilage, and as you can see, after the treatment, there's less of it. So there's more normal cartilage quality. So these are just kind of good data to actually know that there's some structural changes. Not only do patients improve in pain and outcome, functional outcome, but there is some structural changes that are happening. This is a rotator cuff tendon in a scope. This is what it looks like. There's the tendon tear, it's showing there. And after an adipose or a fat-derived therapy, there's some growth of tendon tissue into that region. Patient of ours with a large rotator cuff supraspinatus is specifically a tear here. This is the needle, this is the actual injection, and this white stuff that you can see at the tip of the needle is adipose, that M-fat adipose tissue that's being injected into that big tear, which, as you can see, it healed 1 year after the injection. Achilles tendon, same thing. This is your calcaneus here. This is your Achilles tendon. This black thing is the tear right at the calcaneal insertion. And after, I think this was a combination PRP and fat-derived cells. This was a 1 year post picture. You can see resolution of the tear there. Patellar tendon. This is not a fun procedure for the patient. As you can imagine, this is a sensitive area. But this is your patella here. And this is the large tear before the injection. And 3 months after, you can see resolution of that tear after a fat-derived injection. Tennis elbow, again, this is your lateral condyle. Large tear. So the way that we determine should we use PRP, should we use cell therapy from MFAT or bone marrow, is on the severity of the tear. The more severe the tear, usually more than 50% the actual thickness of the tendon, that's when we tend to favor the cell therapy. And so I'm showing you all these large tears because you can appreciate them more in the pictures. But we see a lot of smaller tears that we treat with PRP more commonly in clinic. So again, healed tear 3 months after the injection. So what to expect? Usually patients are sore for the first week because they go through this inflammatory phase that happens when the injuries heal. You usually don't see them until about a week unless they're just kind of doing you're doing some manual treatments on them or soft tissue treatments on them. But the exercise, usually we let them start at 1 week. So that's usually when you see them. And then it's a progressive strengthening exercise program. After that, we do have a protocol for all that we give our patients that you probably have seen. And then medication-wise, they avoid NSAIDs a week before and after. Just the difference, Chris and I have been harping on this. Make sure that the physicians that you send your patients to, make sure that when they do the procedure, they are using image guidance, either an ultrasound or a fluoroscopy, so that they know exactly where the cells are going, they know exactly where the injury is. If they're not using an ultrasound to do a joint injection, they will miss that at least 50% of the time. And that has actually been published in the studies. PRP, the only way that you can customize it is if you have a cell counter, you know exactly what you're delivering to the patient. And then you track we track our outcomes with data biologics so that we know how to improve it. If there's one treatment that's not working, we kind of tweak it and change it, and make sure that the physicians are participating in research. That way they know the latest and the greatest with regards to these treatments. And I think that's it. So I'm gonna stop the share.